So I think Anthony sent you guys, I think a bunch of stuff yesterday. Did you all guys get that? I told him to share the PowerPoint labeled inflammatory dermatosis with you all.
Yes, we got that.
Yes, and Jacob, Joshua, did you guys get it as well?
Yeah, we have that PowerPoint.
Okay, so that pretty much is going to be the reference guide of whatever I'll be teaching you this year. And when I tell you those are the very highlight important slides, when I tell you to memorize something or something which is high yield that you're supposed to know is there in that PowerPoint. Every year I update it, so it's the most updated version. Um, and then today we finished the blistering diseases last week, and today we will do some questions pertaining to spongiotic psoriasiform interface and blistering diseases. So pretty much like the revision of what we have done till now. So is everybody up for that? Okay. So how do you want to go? We can maybe just rotate between all of you guys. Okay. So which group wants to start first?
We can start.
Okay. Sounds good. They have been the gracious and the courteous ones. Uh, that is good. So let's start with the first one. And nothing that you will say in here is going to be taken against you. And it is important that you actually make mistakes here, because if you make mistakes today, right here, it will stick in your mind. If you speak up and make the attempt, it's going to be very beneficial. So we're all here for teaching, learning. So, don't take anything personally or in the negative way. Okay. Because sometimes I can be mean. So, okay, let's go ahead. This is the first one.
I can start this one.
Okay.
So to me, this looks like either an intraepidermal or a subepidermal blister. It's hard to
Okay.
tell exactly from this slide, but I'm thinking it's more of an intraepidermal blister.
Okay.
And then I
So,
see it looks like a lacy epidermal sign.
mhm,
So I'm thinking like a bullous EM, fixed drug, SJS-TEM.
yes. And if I wasn't to give you any clinical and I expected you to pick up one among them, what would you pick up?
Like a
So
like a
you're
cell type?
what would be the diagnosis if I didn't tell you any clinical and
Oh,
I
I
just gave you?
see. I would say bullous EM.
Okay. So you are completely right. I would have picked up bullous fixed drug because of the pigment dropout, but I'm not going to
Okay.
hold that against you. It's fine.
Okay, thank you.
But the important concept here is, and I think everybody needs to recognize, this is a very commonly encountered entity, and this is the lacy epidermal sign, wherein you see an intact stratum corneum with the dead epidermis juxtaposed beneath it. And whenever this happens, there's always a confusion in your mind. Is this an intraepidermal or a subepidermal blister? This is an intraepidermal blister. And this is how the roof of the blister looks like. And this is what you would see in any interface mediated necrotic process. So this is epidermal necrosis produced by an interface derm, which could be either bullous EM, bullous fixed drug, it could be Steven Johnson, it could be TEN. So that largely is clinical. They will probably give you some second order question with this to diagnose this entity. But if they do not, because of the pigment dropout, I would prefer to pick up bullous fixed drug eruption. But that is not the true scenario. That's not what we do in real life. But for your board purposes, that's what I would want to do. Okay, good. So maybe we can alternate between the Goodman residents and our new friends in here. So this is the second one. So maybe somebody from the other group can take this.
I can take it.
Okay.
We got a different set of slides, I think. So we might be.
Okay.
I think
You
we
got a
got
different
one
set
called
of
SP1 and SP2, but they weren't.
Oh, okay. No worries. That's
Okay.
completely fine.
But what I'm seeing is mounds of parakeratosis that are
Okay.
like kind of adhered on, and then
Okay.
some acanthosis. So normally I go in and look if I'm looking for a little bit of sponge or some extravasated reds.
Okay.
And we have a few extravasated reds. But I still feel like this is giving me more guttate because of how adhered those mounds of parakeratosis are.
Yes. So you want to tolerate gutted psoriasis?
Mm-hmm.
Okay. Yeah, that is the correct answer. And so the the reason you were trying to look for the extravasated red was for what?
Pityriasis rosea.
Okay. So that is not a finding that would either favor it or exclude it. It is often seen in PR, but you do not require to see it, right? So what
Yeah.
you're really looking for is the background. Everything about both gutted psoriasis and PR has to be subtle. So you see the background delicate acanthosis, may have slight spongiosis in both. What really makes a diagnosis in both is the mounds of para. So you did notice the mounds of para, and that's why you started PR. And you do not need to see the blood in the dermis to confirm that. What you just need to see are these dirty mounds or are
Mhm.
they clean mounds? And if they are dirty means that they have neutrophils, right? So these are
Yeah.
elevated dirty mounds because they have neutrophils. So that's guttate psoriasis. Guttate psoriasis, besides having the elevated dirty mounds, also has the stuck mounds. So you always often see the mounds of parakeratosis, which may or may not have neutrophils, often with foci of diminished granular cell layer beneath them. So that is guttate psoriasis. Okay, so good job. And here you see even foci of active neutrophilic exocytosis. So that's also a really good feature of guttate psoriasis. So this is guttate psoriasis. Good job. Everybody got that? Great. I can see heads nodding. Good. Let's go to the next one. Okay. Go ahead.
I can go. I'm Faros on PGY2.
Okay.
So I see kind of a lichenoid infiltrate in the DEJ junction. I cannot see like a basal membrane pretty well, like some sawtooth ridges, kind of hypogranular layer. I see some dysclerotic, the pink one there. It's like cycloid body, body is right there, up there. And so I'm gonna put it like in a lichenoid like an interface LP, but because of the amount of like ortho, I can just like a hyper LP.
So you want to call it LP?
Yes.
Yes. So LP is the correct diagnosis, and as Faraz described, this is a classic papule of LP. So you see the irregular, jaggedy, sawtooth acanthosis. That is a very important feature. You see the band of infiltrate, and this is the beautiful wedge-shaped hypergranulosis. So you see these triangular areas of hypergranulosis, which are wedge-shaped. You see the hyperkeratosis, and there is no parakeratosis, which is what you would expect in a classic lesion of LP. And then all these necrotics down there, these are your cytoid bodies. It's going up to the mid-levels. Most often, they're located at the lower levels. So this is lichen planus. Good. Let's go to the next one. Okay.
Okay, I'll take this one.
Sure, Jacob.
Looks like a subepidermal split. So I'm thinking, what do we have any eosinophils in the split, which would make me think more of bullous pemphigoid. It does look like there's quite a few eosinophils, so I would favor bullous pemphigoid.
Yeah. So this is a classic BP where you see, as you described, a subepidermal blister, which is cell rich and it contains EO. So that's BP. Another clue for BP is the presence of this fibrinous degenerated debris within the blister cavity. So this kind of pinkish fluid, which occurs in the blister cavity, is very classic for BP. So yes, so this is BP, or anything with the word pemphigoid in it is going to be BP. Yep, so good. Let's go. So this is a very classic slide for it. So that's good. So whatever I have actually showed you up till now, they're all diagnostic slides for that entity, for those diseases. Let's go to the next one, which is a slide 5th. Okay. This is a tough one. So I do not expect you guys to know this right off the bat. If this slide is to come to you, it would probably come with some second order question. So can I give you guys the question? Okay, so it will come in as a 17-year-old male presents with a blistering eruption on his legs.
So if it's blistering, and I'm trying to find the blister right now, it doesn't look subcorneal. It doesn't look intraepidermal. It could, I guess, possibly be in the middle subepidermal.
Yep.
And so for zooming in on that, we're going to see if it's cell rich or cell poor. There's a lot going on in the dermis as far as inflammation, but within the actual blister cavity, it's cell poor. So I don't see anything in there. It doesn't really look like ranuncular skin, and you said it was on the leg, so maybe not PCT. It could be like EBA.
Why
or
not
pseudo-
PCT?
I would think that would be more acral.
No, it can happen on the legs.
Okay.
What do you
So it
see in
could
the
be PCT.
dermis?
A lot of inflammation.
Why do you think do you just see inflammation, or you see something else? Do you
It
see
looks like
all
there's a
how
lot of
these
vessels or
there's vessels? The vessels could be because of the legs, right? But he is a little bit young to have all this vascular proliferation, like almost stasis like.
yeah.
And he's not obese. But do you appreciate, like, many of these fibroblasts are oriented parallel
Yep.
and randomly, so that's indicative of a scar, right?
Yes.
So the scar, and as I said in my lecture last week, that the scar can be inflamed. So if you often see a cell poor blister with scar, the inflammation is because of the scar. So there is scar and inflammation. Okay, good. And then going back to the slide in which I put in up there. So what is the differential diagnosis of a cell poor subepidermal blister with scar? Do you guys, not
Could have
Angela or
EBA.
anybody else? Do you remember from Armand? Do you remember?
Yeah, epidermolysis bullosa.
It's okay if you don't, we'll revise it right now. You remember, if it is a cell poor subepidermal blister with scar, what are the 4 blistering diseases you think about?
PCT, EBA.
Yep.
It's only 2 I remember.
The PCT brother, what is a brother of PCT, a brother or sister?
Pseudoporphyria.
Pseudoporphyria, yep. And the last one is?
Bullous lupus.
No, bullous lupus is going to be cell rich. It is dystrophic EB. You guys remember that? So he's a young guy, 17-year-old. So what do you think I'm hinting at?
EBA.
Angela said EBA? How about Armand? What do you say?
I think PCT.
Okay, he's a young guy, 17-year-old. So not many blistering eruption. This is dystrophic EB. So a young adult presenting with blistering eruption on the legs, healing with scar, and you may even see some milia formation with this cell poor is dystrophic EB. But yes, the correct way to approach this would be to do a DIA, because you would want to make sure it's not EBA, porphyria, or pseudoporphyria. And once you have excluded that, that would be the diagnosis. So they probably would give you this, and then they would give you another second order question, like what would be your next step? And that would be your DIF, and then you would be able to make the diagnosis. So more than the diagnosis, I want you guys to approach this slide in the correct manner. And has everybody understood that? The other thing is that do not, sometimes you can ignore stuff in the slide. So this is a true subepidermal split, and this is how it looks like when there is background scarring. So you may ignore something like this. Okay, so always keep your eyes open. Everything that looks like, this often looks artifactual, but it is not. Let's do the next thing, which is the slide number 6.
I can take this one. So, a punch biopsy, kind of like a papular lesion. Was actually the dermis, some like perivascular bland or lymphocytic and eosinophilic inflammation superficially.
Mm-hmm.
I want to say some increase in like either mucin or edema in the dermis.
Okay, there's edema. Yep.
And some dilated blood vessels too.
Yep.
So, altogether like an arthropod.
Or the broader category of it would be? Yep, you're right. This could be induced by a bug. But you see how like the eos are like running away from the vessels. There is edema. There is no epidermal change. So this would be?
Like hypersensitivity.
Yep, urticaria. Yep. So this is urticaria where you see almost like when you look on low power, it looks like nothing is happening. The epidermis is unaffected. But in the dermis, you see, as you nicely described, the collagen bundles are separated because there is edema and there is a perivascular interstitial mixed infiltrate with eos and neutrophils. And these kind of like these cells, like almost like running away from the vessels. So this is classic for urticaria. Good job. Let's go to the next one. I don't know why there was a, okay.
I can take this one.
Okay.
So you see these really nice club shaped, elongated, reedy ridges. And then
Shireen, speak loudly because I can't hear you.
Can you hear me?
Yes,
Is
better.
it better? Okay.
Yeah.
So you see these really nice club shaped, elongated, reedy ridges.
Yep.
Suprapapillary thinning.
Yep.
You've got a really thick corneal layer. And
Yep.
then very minimal granular layer.
Yep.
And so you're zooming in. So we've got really nice vessels in the papillary
Yep.
dermis. And so
Yep.
psoriasis.
Yep, great job. So this is beautiful for psoriasis, where you see these bulbous reedy ridges, the beautiful suprapapillary thinning, the dilated vessels, the loss of granular cell layer. This does not have a lot of active Munro's microabscesses, and you also notice that there is actually some background spongiosis. This is what happens in not the perfect lesions of psoriasis or if it has been partially treated. So it's not uncommon, but the background psoriasiform process is so prominent that you do not need the active Munro's changes to be present. So there is spongiosis, but this would be psoriasis. Good job. Let's go to the next one, which is the 8th. And remember, we can have repetition. I love repetition, actually. So who wants to take the next slide?
I'll take this one.
Okay.
So I am seeing again kind of these elongated, kind of clubbed reedy ridges. Not they seem to be a little bit kind of more wider or bulbous than like the previous one. Maybe a little bit of the suprapapillary thinning as well. I do see some perikeratosis.
Yep.
Maybe a checkerboard pattern there. I can't tell.
Okay.
I don't know if I'm seeing that or not. But yeah, I think like I'm leaning more towards either psoriasis or maybe PRP on this one.
Okay, so now you've come
they're-
down to psoriasis and PRP, and honestly, they both will be in your differential, right? In your boards.
Yeah.
So what do you think? What will you lock your answer with and why?
I think probably psoriasis.
Yes, and you'll be right. Because why psoriasis? What are all these cells?
Just a lot of neutrophils.
Yep. So remember, PRP was a psoriasiform process without neutrophils.
Right.
And also, I think you did mention here, do you see that the granular cell layer is lost here?
Oh, yeah. Yeah,
So
that's true.
PRP is a psoriasiform process with no neutrophils and with retention of the granular cell layer. The opposite
Gotcha.
of that is psoriasis. So this would be psoriasis. And this lesion is what is a classic silver plaque of psoriasis. So a lesion like this has been untouched. So, you would biopsy this, and this is showing beautiful features: the suprapapillary thinning, the bulbous VT ridges, the dilated vessels, the loss of granular cell layer, and this one has active Munro's microabscesses. So that would be psoriasis. Good job. Everybody good? Great. Then let's go to the next one, which is the 9th one. Okay.
So we can see from far away that the epidermis is markedly effaced.
Okay.
And then when we zoom in here, it looks like more like a chronic vacuolar change. The basement membrane is thickened here. There's some dyskeratotic cells as well. The corneum is relatively untouched. There are some atypical vessels there, kind of telangiectatic. So when we're in our chronic interface, we've got connective tissue, so lupus or dermatomyositis.
Yes, and there is some mucin as well. Good. Now, I do want everybody to, this slide is not as simple as it seems. It has a lot of learning points, and I want you to pay attention to this slide because this is a common pitfall. So when you look at it on low power, where does everybody think that this is from? Which part of the body?
Scalp.
Okay, scalp or like the head and neck, and likely the scalp because it has these long, not likely, like it has these long hair follicles. So you're correct. Would everybody agree that there is not a whole lot of inflammation? Yes. So this is a common mistake. So when you look at it and you are like, okay, there's not a lot of inflammation. And when you go to this part of the biopsy, tell me what would people describe this as? Just open your speakers and just blurt out. What do you think this is? How do you describe this?
Dermal edema.
Okay, good. So you're being honest. So dermal edema. So what is that, Angela?
I would say almost like reticular degeneration.
Okay, so Joshua, you were right, and Angela is also right. So dermal edema. So would you think dermal edema to be associated with the connective tissue disease? What did I say last time to you guys? That, or maybe I didn't say it, but if I didn't say it, I'm telling you now, you would not see spongiosis and dermal edema in a connective tissue disease, right? And by connective tissue diseases, we are referring to lupus and dermatomyositis. You don't see that, right? But you just right now made a diagnosis of connective tissue disease, didn't you? Then what is this? And this is the pitfall I want you guys to remember. So go to the next part of the slide. This is where you nicely demonstrate, as Amanda was describing, that there is a fuzzy basement membrane and it is a thick basement membrane which has degenerated. So it is important for you guys to remember that when the connective tissue disease, the thickened basement membrane, reaches its peak of destruction, that's how it will look like. It will look fuzzy, degenerated. It looks like fluid, but this is not fluid. This is all the degeneration at the DE junction of the basement membrane has happened. And you see how fuzzy it looks here? So this is the continuation of that process. Okay. And this is not an uncommon finding in systemic lupus and dermatomyositis, which actually tend to be pauci-inflammatory. There is subtle mucin in here. And this is how you see a dissolved basement membrane, which kind of looks like edema, but it's not, because you can see that there is corresponding epidermal atrophy, necrotics, and hyperkeratosis associated with it. So this is a beautiful slide, and I would highly suspect that this patient, because of the telangiectasia and the sparse inflammation, either has systemic lupus or dermatomyositis, and my bet would be on dermatomyositis, because that often will do that. This is the kind of finding you also sometimes get in a Gottron's papule. And when you get in a Gottron's papule, that's why it gets misdiagnosed as eczema. And you can see why. Okay, so even though like this slide has a lot of teaching points and lot of, if you can pick up the thick basement membrane in this slide, you will never miss what a thick basement membrane means of connective tissue disease. Is everybody clear on that? Okay, good. Let's go to the next one, which is the slide 10. I have a dot there. Okay, let's go to the dot. So what disease process do you think we are in? So we'll start with that.
I'll take this one. It looks like
Okay.
a lichenoid, kind of have a band like,
Okay.
infiltrate.
A little band like over here. Yes.
Some basket weave on the top.
Good. Yep.
The inflammation doesn't seem to track down the hair follicle.
Okay.
Seems to be, and let's see, the basement membrane looks.
So you described an intact stratum corneum, right?
Yes.
So corresponding to that, what should be the basement membrane?
Um,
It should be an acute process, right?
yes. Yes.
Yes. Okay. And what do you see in here? What are all these?
Dead.
Dead
mhm.
cells. Yep. And there are a lot of them, right?
Yeah. So we have necrotic.
Necrotics up and down. Yep.
Mhm.
So it's an interface.
Yes.
Okay. If it's an interface, then how do you classify it? Is it acute or chronic?
Acute, I would say.
Yep, acute. And then what are the 4 diseases in acute interface that they test you for your slides?
We have fixed drug,
Yep.
SJS,
So
TEN.
yes, so basically 4 diseases: acute GVHD, EM, fixed drug, and pityriasis lichenoides. Things like SJS and TEN, they are included in the category of EM, right?
Yes.
And for
yes.
SJS and TEN, you want to see the lacy epidermal sign. So you want to see a dead epidermis, right?
Mhm.
So the diseases are 4.
Yeah.
Simple to remember: acute interface, 4 diseases: acute GVHD, EM, fixed drug, and pityriasis lichenoides. So among those 4, which one do you think this is?
I saw a few EOs, but I don't think it was extensive.
Yep.
Have at least some pigment dropout.
Okay. Little pigment dropout. Yep.
So I would say fixed drug.
Okay. I wouldn't fault you on that. Because you do see a little pigment, it's not a whole lot. To give you a slide like this, there definitely will be a second order question with it. This could be EM or fixed drug. That would be the differential. Yes. This is from a patient with EM, but absolutely your differential is right. Now you tell me one thing. Why didn't you pick up GVHD, acute GVHD? Because it is very inflamed.
Okay. Oh, okay.
Acute GVHD is an invisible dermatosis. So you just get vacuolar and necrotics, but you don't get inflammation. That's why you didn't pick up GVHD. And why didn't you pick up pityriasis lichenoides?
I'm not sure.
Okay, you didn't pick up pityriasis lichenoides because pityriasis lichenoides, all the layers are affected. So there is crust on the top. In the epidermis, actually the necrotics are not that prominent. It's the lymphocytic exocytosis which is prominent. So it's like almost like a sandwich sign. You have crust on the top, you have limbs in the epi, but actually the necrotics are not prominent. And then you have extravasated blood and you have the inflammation, which this does have. But it is because of this epidermal change, you didn't pick up pityriasis lichenoides, and it won't be pityriasis lichenoides because here the necrotics are too obvious. There, the limbs in the epi are too obvious, and you have a nice crust. So we will be dealing with slides of pityriasis lichenoides, and I'll explain you that. But that's why you didn't pick up. Okay?
Thank you.
So is everybody clear on the approach to the slide? Okay. Let's go to the next one. Okay. So what do we think is happening here?
I can take it.
Yeah.
So we have some subepidermal split and then
Yep.
lots of neutrophils in the papillae. So
Yep.
I'm thinking DH. Other thing on the differential is linear IgA.
Good. So this is a slide that they give you. Now, if they give you a high power, if they give you this, you just have this, and you'd have both DH and linear IgA in the differential, what would you pick up?
I'd put DH.
DH, exactly, because this finding is pathognomic for DH. However, if they just gave you this, then what is the differential?
Linear IgA or bullous lupus.
Or chronic bullous dermatosis of childhood. Exactly. So this part is DH and this part is the linear so in linear IgA, bullous lupus and chronic bullous dermatosis of childhood, you have a subepidermal blister which doesn't concentrate. The neutrophils don't concentrate the tips of dermal papillae. They're more in a linear fashion and it's neutrophil rich. Okay. So this doesn't hold true for real life. So you can see that this patient is actually DH, but has both the findings. So if you were to biopsy just this part of the lesion, this would look like linear IgA, but it's not. But for your board purposes, yes, it is. Okay. And the other thing is that, when you start thinking a lot, you start imagining eosinophils. Because if you just had this and I did not tell you anything else, I bet half of you would go in the BP direction. Okay, so be careful of the cells that you're looking at. It's not that linear IgA doesn't have EOs. It will have EOs, but the predominant cell type should be neutrophils. And don't mistake red blood cells for EOs. Okay, so just that would be the time when you want to pay a little attention and be sure. The other thing that you have to do, you jumped to DH, which is good. But did you make sure about one thing that you should not miss when diagnosing DH?
Vasculitis.
Exactly. So you want to make sure that the vessels are normal. Here there is neutrophilic exocytosis, which would be expected in DH, but there is no fibrin deposition because I tell you, leukocytoclastic vasculitis can look exactly like this. So you have to pay attention to the vessels in the dermis to make sure you're not missing LCV. Good job. Okay, let's go to the next one, which is slide number 12.
I can try this one.
Okay.
Looks like we have a subepidermal blister, but it's in the cell pore variety. So kind of on the differential would be like EVA, porphyria, pseudoporphyria, or like EB or bullous diabeticum. Kind of depends on the DIF positivity.
Yep. Great job. That's exactly what your answer should be. It's a cell-rich subepidermal, cell-poor subepidermal blister. So you're thinking about DIF positive, DIF negative entities. DIF positive would be EBA, porphyria, pseudoporphyria. DIF negative entities would be bullous diabeticorum, epidermolysis bullosa, and your cell-poor subepidermal blisters because of drugs like NSAIDs. So 3 and 3 on each side. And yes, anything could be the answer. You'll have to look at what they are trying to ask you. Now, if they do not give you any second order question and they expect you to diagnose this, so then you want to look at this and you want to look at the vessel. So what do you think the diagnosis here is?
Maybe more PCT.
Yep, because you see perivascular hyalinized vessels in the blister base. So that is where your donut vessels of the DIF will deposit. So yes, so this is from a patient with porphyria/pseudoporphyria, and both porphyria and pseudoporphyria will be indistinguishable on histology and on DIF. The only way to distinguish between them is you have to do serum and urine porphyrins and obviously correlate it with the clinical findings. So yes, so that is the correct answer. Good. Let's go to the next one, which is slide 13. Okay.
Has everyone gone? Am I up again?
Yeah.
Okay, perfect.
It's free for all.
Okay.
Yeah.
So this looks like a interface dermatitis. It has a
Okay, hold on, Michelle. Tell me,
okay.
why did you say interface dermatitis?
So one thing that caught my eye is the thick basement membrane. So I'm thinking that it's like a chronic vacuolar.
Okay, point to me where are you seeing the thick basement membrane?
Right, like all just that thick,
All
all the
this?
pink material, yes, underneath the basal layer though.
Okay, so fine. If
Am
you're
I just
thinking that, what is
completely off?
happening? No, that's okay. I want you to, you're on the wrong track right now, but you'll get on the right track very soon. This is fine. I want you to, Michelle is our first year resident and she can absolutely do this. You cannot do this in your second year, but you can do this now.
Okay,
So
great.
what do you think is happening in the epi right above it?
Okay, so now look, I'm seeing like a epidermal split.
Exactly.
Is what I'm
You
seeing.
see,
Okay.
right? Because everything
Yes.
in the epi is missing. But what is left behind in the epi?
The basal layer.
The basal layer is left behind. And what are all these?
Those are all basilar cells, keratinocytes.
So the cells that are left behind, right? Right? In the epi.
Tombstoning.
The tombstoning. So you see that they are forming here a nice tomb, but the rest is all lost.
Yes.
And even with the cells that are left behind there, what do you think is happening?
They're splitting apart.
They're falling apart.
Falling apart.
Falling apart or splitting apart, that's fine. And what is that process called?
Acantholysis.
Yep. So in summary, you're describing to me an intraepidermal blister with tombstoning and suprabasilar acantholysis. Is that correct?
Yes.
This is a tombstoning, right?
Yes.
Good. So now is the basement membrane relevant?
No, not at all.
So sometimes what you see, your eyes will deceive you, right? So you have to go to the more easy findings in the slide. Like basement membrane thickening is a kind of a thing you're forced to think about it, right? Like nobody likes to want to see that. It's painful to the eyes because it's a difficult thing to diagnose. So you go to the more obvious findings in the slide, right? That should catch your eye. And then what is happening with this acantholysis? What do you think this unit is right here?
A hair follicle.
A hair follicle. And the same process that you saw here, which was your acantholysis, what do you think is going? It's going down. You see it's involving the hair follicle.
Mm-hmm.
You see the whole picture here?
Yes.
So what do you think the diagnosis is? This is another hair follicle. It's also involving the hair follicle. Do you see that?
I do, yes. So this would be pemphigus vulgaris.
Pemphigus vulgaris, yes. So this is a beautiful slide for pemphigus vulgaris, wherein you see the suprabasilar acantholysis with the tombstoning and extension and involvement of the hair follicles. You see it's involving the hair follicle and growing down the hair follicle. So that's pemphigus vulgaris. Good.
Thank you.
Yep. Everybody got that? Good. Then we have your next one, which is slide 14. Okay. Okay,
I can go if it's okay.
hold on. You want to take that?
Sure.
Yes, go ahead.
So shape biopsy, I see some lichenoid infiltrate
Yep.
upper dermis, and there is a, it seems like an intraepidermal blister. Yes. So whenever it comes in intradermal, I have to see if it looks like an interface. So top differential, it can be EM, SJS, Fixrock.
Okay, so again, let's back down. Again, Faraz is our first year resident here, so that's okay. Okay, does anybody else want to take the slide?
There was one similar, I think, on our test that we did the other day where we had like these well circumscribed areas of inflammation that were near the epidermis, but then there's also like clubbed reedy ridges around it, surrounding it. So then I was thinking more of like lichenitidis, and there's another one in the slide that looks more like that.
Yes, so these are lichenoid papules. You see, they have uninvolved reedy ridges in between them. This is one papule, which has the nice ball and the claw. And this is the claw, this is the ball. This is the claw, this is the ball. Because, and it is also granulomatous. You can actually see that there is a giant cell in here, which is very classic for lichenitidis. As with any lichenoid process, the lichenoid infiltrate can produce you secondary subepidermal vesiculation. So this is like kind of like a max dose of space that you are seeing. Whenever you see a split at the DE junction like this with the band-like infiltrate, which is at the base of the split, that's lichenoid producing the split. And there is epidermal atrophy overlying it, which is what you always see in lichenitidis. So the epidermis overlying the lichenoid infiltrate becomes atrophied. So this is lichenitidis. Everybody gets that? Okay, good. Let's go to the next one. Okay.
I can take this one.
Okay.
So this is, you can see widespread, supravasal, incomplete acantholysis. It's in, yeah, I guess it's widespread, so it's involving a large part of the slide. There are a few dyskeratotic cells, but minimal. So I think this gets Haley.
Shireen, be louder because I can't hear you.
Sorry. All right, so I see widespread, incomplete acantholysis.
Okay.
Is involving a large part of the slide. There are a few dyskeratotic cells, but they're very minimal. And so I think this is probably consistent with Haley.
Okay, so so what is the process of acantholysis that you're seeing in here? This is called the dilapidated brick wall appearance, right? There is incomplete acantholysis. The cells are falling apart, but they have not yet fallen apart. So they are holding on to one another. There will be parts of Haley disease which will look indistinguishable from tombstoning and pemphigus, right? So that would be something that is going to be in Haley disease. But the key is to look for areas which look like this. The incomplete acantholysis, the dilapidated brick wall. There is no follicular involvement in this section, which would also go with Haley disease. So this is the finding, and you see the incomplete acantholysis. Good job. Everybody got that? Okay, let's go to the next one, which is 16th. Okay.
I can go for this one. So we have a subcorneal blister, it looks like. And when we talk about subcorneal blisters, we look for a couple different things like tinea or impetigo, but the base, or not the basement membrane, the epidermis looks actually pretty thick and acanthotic. And then when you
Okay.
zoom in on the blister, it looks like it has like neutrophils in it. So I was thinking that this was, and also looks like there's a stratum lucidum layer maybe, but I was thinking that this was pustular psoriasis.
Okay. So
Or not.
to everybody else, can you describe to me what is there in the subcorneal blister? And let's be honest, how many of you think there is bacteria in here? If you don't think it's bacteria, it's fine. Just blur out. How many of you think there is bacteria in here?
I feel like it has the fuzzy look of bacteria.
Yep. So, yeah. And you're being honest because a lot of you sitting over there are thinking there is bacteria in here. Will that alter the diagnosis? Because if there is a subcorneal blister with neutrophils and bacteria, then what is the diagnosis you're thinking about?
Bullous impetigo.
Yes, so that is very crucial to understand in your brain, are these bacteria or not, because that is going to be in your differential. So let's be honest, if you guys think there are bacteria, let me know because there are no bacteria in here. Okay, for you to see bacteria, there's going to be a next slide which is coming on, which I'm going to be showing you, or the next few slides I'm going to be coming on, which are going to be showing you. Okay, let me just pull it up. I think it is the next slide. Is it the next slide? It may not be 16. Maybe I think it is this slide. Yep. Bacteria has got nothing to do in this slide, but they happen to be there. This is bacteria. You see that? When you are seeing bacteria, they should be appearing in clusters and colonies. These are called your grape clusters and collections of bacteria. So this is bacteria and this is not bacteria. Whenever you have a lot of neutrophils, there will be debris and a bluishness and a fuzziness, which can be misinterpreted as bacteria. This is not bacteria. This is a degenerated acantholytic cells, and there is debris and stuff in the background. Okay, so that is clear. So that is out. So it's not bullous impetigo. So it's a subcorneal blister with neutrophils, right? So what is the differential that is left in here? Let's go down that list that I tried to make you memorize, right? We have bullous tinea. Bullous impetigo is out. Can this be staphylococcal scalded skin syndrome? What is the only subcorneal blister which is cell poor? Staphylococcal scalded skin syndrome. This is too inflamed for that, right? So it's not staphylococcal scalded syndrome. Then you have pustular psoriasis. Yes, it could be pustular psoriasis, subcorneal pustule. It has neutrophils. Then comes AGEP, right? Why is this not AGEP?
Would there be more like eosinophils in the dermis?
The eos would be very obvious. You will not struggle with them at all. Like you can go up to slight high power and you should be able to readily see them. So it's not AGEP. Then comes your pemphigus foliaceus. It could be pemphigus foliaceus. Why not? Right? Pemphigus foliaceus. If you are thinking about bullous impetigo, you're always thinking about pemphigus foliaceus because pemphigus foliaceus could be bullous impetigo like, or it could be staphylococcal scalded skin syndrome like. So this could be the bullous impetigo kind of staphylococcal scalded pemphigus foliaceus, and you do not need to see the bacteria in there, right? So that's a fair question as well. It could be. And then lastly is this Sneddon-Wilkinson disease, which would be a diagnosis of exclusion. Okay, so when they are putting a multiple choice in there, they either have to tell you something in there. This is from a patient with pustular psoriasis, and that is correct. But there has to be something in there that points towards that, or if it is not, then that has to be the only question. But here, the diagnosis could very well be Sneddon-Wilkinson disease. Okay, either it's just that or nothing else in the differential, or if it is not multiple other things, then they have to give you something which excludes that particular entity. Do you guys get what I'm trying to approach and how I have approached this slide? There's obviously no fungus in here, so it's not bullous tinea. And in bullous tinea, the stratum corneum, like above, like it always looks very dirty. It's very crusted. It's never this well-formed pustule. This is what I call a sterile pustule. Does everybody get how to approach this? And the key is not to mix this stuff with bacteria. Okay. Let's go to the next slide, which is slide number 17. Okay.
I can try to take this.
Okay.
So we have a subepidermal split here. I think those might be neutrophils.
Yep.
So, I'm kind of thinking again along the lines of linear IgA,
Yep.
DH, bullous lupus,
Yep.
possibly.
Okay. And bullous dermatosis of childhood. Yes.
Okay.
And among those diseases that you stated, what is the one that you can exclude based on the histology for your boards?
Maybe DH?
Yeah, because they're not concentrated at the tips of dermal papillae. But absolutely, you cannot distinguish linear IgA, bullous lupus, and chronic bullous dermatosis of childhood. So either one of them would be the right answer. This is from a patient with linear IgA, but to diagnose that, you would need a second order question with it, like a positive DIF finding, which would be, or like a drug history, something to suggest that it would be that. Okay, good. Everybody gets that? Okay. The next one. And this is a really important slide, right? They love to test you on this. So what disease do you think this patient has? Which part of the body has this specimen been taken from? And what kind of a processing that is? Like what kind of sectioning is that?
Horizontal
Yep.
sectioning through the scalp.
Okay. So we're dealing with an alopecia. Okay. So what do you think your diagnosis would be? Is it a scarring or a non-scarring process?
It looks like a scarring alopecia
Yep.
with loss of the follicular ostia and almost like polytrichia, sort of. Well,
Okay.
maybe not quite, but it's extremely inflamed.
Yep. And there are no sebaceous glands, right?
Yeah, no sebaceous glands.
So you're scarring. So when you think about a scarring alopecia, what are the diseases that you're thinking about?
Discoid lupus.
Yep.
Lichen planus pigmentosa.
Okay.
Centrifugal.
Okay.
Superficial alopecia.
Yep. Folliculitis decalvans. Yep. Yep.
Yeah,
So those are the common ones that you think about. So so what based upon again, in real life, this is not generally the way we think, but for your board purposes, this is how you will think. So based upon the diseases you have mentioned, so it's lichen planopilaris, right? So based upon the diseases that you have mentioned, DLE, LPP, central centrifugal cicatricial alopecia, and folliculitis decalvans, what do you think you can exclude?
Well, there is in LPP.
Yep. Why did you exclude LPP?
Because there's
because there is lots of inflammation.
Yeah.
Right? And the amount of inflammation is out of proportion. You actually are not seeing any perifollicular fibrosis, right? Maybe a little here. But the classic finding of LPP is the concentric perifollicular fibrosis in a mucinous fashion. Okay? Let's see if I have another alopecia in here. I do not have it, but me just go to, give me 1 minute. Oops, went to the completely wrong folder. Here. This is what you want to see in LPP. You see the concentric mucinous perifollicular fibrosis?
Yeah.
With minimal inflammation, and how different it looks from what I just showed you, right?
Yeah.
So based upon that, that is not LPP, right? Do you agree?
Yeah, I agree.
Yep. So let's go back into your set right there, and we are here. Okay, so that's not LPP. So now you're left with lupus, centrifugal cicatricial alopecia, and your folliculitis decalvans. What else can you exclude? What do you think the skin type of the patient is? So CCCA is a disease you see in African Americans, right? So you typically see dark hair follicles and you see epidermal pigmentation. So I know that I'm dealing with not an African American patient because there is no epidermal pigmentation. That's a quick way to exclude CCCA.
Gotcha.
Okay, it is not CCCA. And why is it not folliculitis decalvans?
No neutrophils or.
Exactly. Typically, you have if this is that inflamed subtype of folliculitis decalvans, you would expect to see neutrophils. You are not seeing any neutrophils. So this is lupus. This degree of chronic lymphocytic inflammation around the hair follicles with scarring in a scarring alopecia, and you see the overlying epi. This is your fuzzy thick basement membrane. So the entire epidermis is also being affected. So this is lupus. Does everybody get that? So the inflammation in lupus is much more as compared to that in LPP. It's the perifollicular fibrosis is much more prominent in LPP as compared to the inflammation. Do you get it? Good. Let's go to the next one, which is your slide 9. So we all know that there is bacteria in this slide, but has got nothing to do with the diagnosis. I had showed you this one. These are all bacterial colonies in here.
I can take this one.
Okay.
All right. So you see it's just really thick from top to bottom. So a lot of hyperkeratosis, irregular acanthosis. It's localized. It's one lesion. And so it's nodular. And then you have like elongated, stretched, kind of vertical papillary dermal like collagen, and then also the vessels. And so because it is one lesion, I think prurigo.
What if there were multiple lesions?
Or like if it was like a plaque, maybe LSC.
The difference between prurigo and LSC is not one versus multiple lesions, is basically a papule or a plaque, right? So it could be the prurigo or LSC, but you won't know that on histology, so you don't really need to mention that. But what are these? This is another pathognomic finding of either LSC or prurigo, and what is that?
Plugged hair follicles.
The hypertrophy thick follicular infundibular unit. This is like the most important finding you want to recognize is the thick hair follicles. And then, as you said, the stretched out vessels and the dermal collagen fibers with the entirely thick epidermis. And yes, this patient has been picking at his lesion, so it has become secondarily infected. And that's why you see the bacteria. So this would be either prurigo or LSC. Good. Let's go to the next one. Okay. Who wants to take this one?
I can go for this one.
Good job. Okay.
Atrophic epidermis, some
Yep.
basement membrane, periodontal inflammation, lymphocytic inflammation, increased mucin. So thinking like connective tissue disease.
Yep. Perfect. So this is and this is again a beautiful example of a thick basement membrane. Begins here, it ends in here. Is atrophy because there is effacement of the reedy rich pattern. Is hyperkeratosis. There is inflammation around the hair follicles and the vessels. So you're already, with the thickened basement membrane, you're already at a connective tissue disease. Now you're just supporting your findings, right? There's follicular inflammation, there's inflammation on the vessels, and this one also has mucin. So there is subtle mucin in the slide. So this is going to be a connective tissue disease, which could be lupus or dermatomyositis. Good. Okay. This should be an easy one. Okay.
We are acral, and there are some
Uh-huh.
intraepidermal vesicles.
Yep.
Dyshidrotic eczema or Pomflex.
Yep. Or contact derm, you wouldn't be able to say, but most often when they're showing you intraepidermal fluid blisters on acral skin, they want you to pick up dyshidrosis. Yep. Or Pomflex. Good. We have the next one, which is 22. Okay, this one is a challenging one, so I'll help you guys with this. So this patient has also presented with what looks like a blistering eruption.
Dr. Anand, I have a quick question.
Yes.
The last slide for the dyshidrotic, do you not need to see any like spongiosis?
So yes, so this is all fluid-filled blisters from spongiosis. So you see there is crust. There is intraepidermal fluid-filled blisters with the serum.
Yeah.
And there is fluid in the epidermis because there is prominence of the desmosomes. And then there is inflammatory cell exocytosis. So that's all. So it's an acute spongiotic, right? That's why you're getting intraepidermal blisters. You get that?
Yeah.
Okay. So that is decided. Everybody got that? Sorry, I was a little quick on that. And so it's like more of the low power view, right? So you this is one diagnosis where you should be like, okay, yeah, thick skin, blisters, fluid, dyshidrosis. Okay. Let's go to now to the 22. Oh. So this patient has a blistering eruption, which is dermatomal. Now, can you help me? What is all this? This,
Yeah. Like
yep.
Like we're looking for the 3M.
margination, multinucleation. Oh, sorry.
What is that?
I said molding, multinucleation, and margination.
Yep. So these are the 3 M's where you see the nice nuclear molding, margination of chromatin, and multinucleation. So this is herpes infection. Now, herpes infection, remember, is a blistering eruption which looks really busy. So there is lichenoid inflammation. There is a blister here. There can be superficial and deep perivascular, perifollicular inflammation. So the slide can be very distracting, but the answer is very simple. Because all that, if you see herpes in your differential, that's all that you need to find, which can be very obvious if you know what you're looking for, right? So sometimes a reverse thing especially when you're dealing with infections can be helpful because you know what you're looking for. Good, so this is herpes infection. That can mimic a blistering disease. Okay, so this is the next one. Okay. Who wants to take it?
So this pattern is acanthotic dyskeratosis. We can see the
Yep.
corons and core grains in there.
Yep.
And it's just one kind of little papule of it. So I would say Grover's for this one.
Yes. So this is a beautiful reaction pattern of acantholytic dyskeratosis, where you see the core rons and the core grains. So you can see in here, these are the core rons, where you see the perinuclear halos with the very dense granular cells. And here are the core grains, where you see the grainy kind of necrotic, grainy kind of hypereosinophilic cells. So that is the reaction pattern. And these are tiny papules. They're separated by the nice in normal intervening epidermis. There is no follicular involvement, so it's not Dayer's disease. So this would be Grover's. Everybody gets that? Okay. Okay. The next one. Okay. Again, there's no wrong answer here. If this is an important reaction pattern, so we will talk about the differential in this, and we will talk about how to approach this slide.
I can go. It looks like a spongiosis pattern.
Okay, so why do you say spongiosis?
I mean, I see like the spaces between the cornices are like there's a white area like desmosomes. I can
Okay,
see
so
those
you are
areas.
saying that there is pallor, okay, but is that really fluid? Because if there was fluid, with this degree of fluid and the cells appearing separated and pale, would you expect to see crust overlying? There's no
No, there's
crust.
not. Yes, that's
And
true.
if this was spongiosis, why isn't there inflammatory cell exocytosis with it? Right? So this is probably something which is mimicking spongiosis, right? So it's not spongiosis. But it is pale, you're right. And it looks like the desmosomes are separated out. Okay. What is the other which is the prominent finding in this slide? Isn't the epidermis very thick? And there's
Yes,
hyperkeratosis? And what are all these cells? What is this? Dark blue granules. What are those?
Neutrophils,
What is that?
lymphocytes.
Nope, these are not lymphocytes. These are hypergranulosis of keratohyalin granules, right? So this is a lot of dense hypergranulosis with the prominent keratohyalin granules. When you see prominent hypergranulosis with prominent keratohyalin granules, you actually do think about a wart, right? But if this was a wart, yes, the background epidermal acanthosis, the hyperkeratosis would go with that, but the pallor doesn't go with that. So this is not a wart. And also along with the pallor, what are these? You see these pink inclusions inside the cells? So these, what are these pink? So pallor, hypergranulosis, pink intracytoplasmic inclusions. Where do you see that?
Like infection, like what be?
What is that? It's okay. Anybody else can answer.
EHK.
EHK.
Yep. Epidermolytic hyperkeratosis, and that is EHK. So in EHK, the low power actually looks like a wart because of the thick epidermis, the hyperkeratosis. The high power also looks like a wart because you see the hypergranulosis, but you shouldn't see the pallor. So what makes the diagnosis of EHK is the hypergranulosis with the pallor of the stratum spinosum. And why is it pale? Is because it is intracytoplasmic dissolution of the keratin filaments. And that is why it looks like there is spongiosis, it's pale, and those clumped keratin inclusions keratin filaments will form these pink inclusions, which you see in here. So it's keratin 1 and 10 mutation. So then they can ask you a lot of second order questions, right? And that is there in the PowerPoint slide that I shared with you. It could be congenital bullous ichthyosiform erythroderma, ichthyosis bullosa of Siemens. It could be the epidermolytic PPK, such as Warner syndrome. It could be an incidental EHK. So, all those things, or the keratin mutations with you should know. The other thing that people confuse this with is a psoriasiform necrolytic dermatosis. So, for example, the glucogonoma or the necrolytic migratory erythema, because of the pallor. But remember, in those diseases, the pallor is not in the it involves the stratum spinosum. It's a top layer which is basically pale, and also you do not get the hypergranulosis in that entity. So this would be necrolytic migratory erythema. Guys, 1 minute. Not would be necrolytic migratory erythema. I'm teaching the rest, and I'll call you back. So it will not be that. So this would be EHK. So do you guys make the diagnosis on that? Did everybody get that? And did everybody get the differential? Okay. Let's go to the next one, which is the slide 26. So again, this is very thick, right? There is background epidermal acanthosis, hyperkeratosis, hypergranulosis. I'm teaching the residents, I'll call you. Oh. Yes, hi. So they see the epidermal acanthosis, hyperkeratosis, and yeah.
Again,
what do you
this
see
one
in
looks
here?
like there's some acantholysis as well within the epidermis, and then it looks like there's some core rons too, and some core grains. But this lesion looks a lot bigger than the one that we previously saw for Grover's. So Terriers, maybe.
Yep. So there's massive background hyperkeratosis. Everybody recognizes the nice core rons and the core grains. There is follicular involvement as well in this lesion. So you can see the follicular involvement. So this is Darius disease or keratosis follicularis. Good. Everybody recognizes the core rons and the core grains, right? Okay, good job. The next one is okay. So what is happening in here?
There's a tinea in the stratum corneum.
Yep. Yep. So this is again a subcorneal split with neutrophils, but the stratum corneum, you see how the pack, that is what is called the sandwich sign, because the fungus is all compressed between the layers. And the stratum corneum looks really dirty, even though it's separated. So this is a tinea infection. Whenever you have a very dirty looking subcorneal split, that's almost certainly going to be tinea. There is more fungus in here. It's fungus in here. It's like a fungal party happening in here. And these were all fungus in here. So that is tinea, bullous tinea. Good job. The next one is 28. Okay. So again, I just need for you guys to how to approach this slide.
That looks like a subcorneal split with sort of focal acanthosis around the granular
Yep.
layer, so it looks more like pemphigus foliaceus.
Okay, what would be your other differential be? Is it cell rich or cell poor?
It's cell poor.
What else would you think about?
So you'd think about bullous tinea, staph scalded skin syndrome.
Will you think about bullous tinea?
I guess that would be rich.
Yep. So the only cell poor subcorneal blisters are Staphylococcus scalded skin syndrome and pemphigus foliaceus. Okay, so either one of them could be there as a single choice. If they have both, then they have to give you a second order question with it. And obviously the distinction is going to be straightforward clinically, and also like one is DI positive, one is DI negative. Does everybody get that? Good. And we have the next one, which is 29.
I can go on this one. See kind of an intraepidermal blister here. Looks like possibly see some corons in there too. I'm kind of leaning towards maybe again like Derrieres for this, but
Yep. Grovers, because you see here there's a tiny papule here, there's a tiny
yeah.
papule there. Yep.
Yeah.
And this is belongs to probably a hair follicle, but nothing, it's uninvolved. This is Grover's disease. Good job. You have the next one, which is slide 30. Okay.
You can take this one. So you have a band-like infiltrate obscuring the DEJ. You have these like sawtooth kind of acanthosis and then wedge-shaped hypergranulosis.
Yep.
I think LP.
Yep. So this is again classic for LP, the band-like infiltrate, the beautiful irregular sawtooth acanthosis, the wedge-shaped hypergranulosis, hyperkeratosis, minimal to absent para. So that will all be LP. Good job. We have the next one. Okay. Okay.
Okay, I can go. So you have very mild spongiosis. Very, very subtle. And then you have these like lifted, like mounds of like a tea kettle, like a lid of a tea kettle. So lifted mounds of parakeratosis.
So say that again. I heard the mounds, and then what else?
Like lifted mounds.
Yep, lifted mounds, clean
like
mounds.
Yes. And then very, very subtle mild spongiosis. So I think PR.
Yep. Cassidy, do you agree?
Yeah.
Okay. So you see, again, everything about the slide is really subtle, right? So you compare this with the slide of the gutted psoriasis. The background looks similar, but these are clean mounds and those were dirty mounds. And there is some extravasated blood as well, but you really don't need to look for that. Okay. So good job. You have the next one is 32. It was a punch and then something happened in here because this kind of like fell apart. So the answer is in here. Anybody wants to take it?
I think I'm maybe seeing margination, multinucleation, and molding.
Okay, tell me where.
A little bit in the middle of the screen, there's some cells there, and then a little
Here?
bit lower.
Oh, here, you're saying.
Yeah.
Oh, wow. Okay. They are collected together. Multinucleation is present, but it's probably not molding because the multinucleation molding is present, but it's not really margination, because if you compare it, the nuclei to the background cells, they all look similar. Like this. This I know is for normal and it looks like that. Okay. So so this is again an important pitfall. I'm glad that you're recognizing that, because sometimes when there is too much of either cell death or acantholysis, it can mimic herpes. So you have to be absolutely sure. So again, back down. The rest of the reaction pattern doesn't fit for herpes because you see there is not much inflammation at all. Right? So, and then this part doesn't make sense with herpes because this is probably the acral skin.
A lot of death and squalor.
Yes. So what does this remind you of?
Like SJS or TEN.
Exactly. This is the lacy epidermal sign, wherein you see an intact stratum corneum with a dead epidermis juxtaposed beneath it. And what all here is the dermal edema, which you will always see in the EM Steven Johnson TEN category. So this is, and again, that it's in that category. This is from a patient with actually bullous EM, and you cannot differentiate bullous EM Steven Johnson TEN based upon the histology. So it's nice that you made, and see, it is very inconsequential, right? Like at this power, if I see, like if that is the hepatic inclusions, they're prominent. They're like, you will be able to readily see them, right? This is like one cell. So sometimes it's nice to look at the big picture and not to get bogged down by a single isolated finding. Okay? Yep. So this is bullous EM. Good. 33. Okay. So what do we see in here again?
This looks like a subcorneal blister.
Yep.
And it looks like it is cell poor.
Yep.
So SJS or
SJS?
Sorry, Staphylococcus scalded skin syndrome. I'm so sorry.
Yes.
Or
that reminds me when my son comes back and he is a sophomore and he's famous for doing that. He'll come back. Oh, I did a silly mistake.
Yeah, I did do a silly mistake there.
Yes, yep, yeah. Staphylococcus scalded skin and
pemphigus foliaceus.
Yep, yeah. So this is pemphigus foliaceus or Staphylococcus scalded skin syndrome. Again, it's a subcorneal blister with acantholysis, which is cell poor. So you would think about both those diseases. Good, and there will be something to help you with the answer in there. Okay, we have the 34. This is a very important board slide. For some reason, they love this. So what do we see in here? Kendrick, what do we see in here? Sorry, picking on Kendrick. He was the most intently looking on the screen.
Looks like a lot of like lymphocytes or neutrophils.
Neutrophils. And what is the location?
We're subcorneal.
Yep, so subcorneal, lots of subcorneal neutrophils, and the dermis looks busy. And what do you see in the dermis?
A lot of eosinophils.
Eosinophils. So what do you think this is?
Could be like AGEP. I think I
HF.
remember you talked about that with a
Yep.
lot of eosinophils.
Yep. So the top looks like a pustule, subcorneal pustule with neutrophils, and the bottom has plenty of dermal eos. Like you will easily recognize it. Sometimes the eos can also get mixed with the neutrophils. So predominantly it's pustules with neutrophils in the epi. So that is HF. Good job. And then 35. This is the last one. And this is
It looks like we have a lot of parakeratosis, no granular cell layer, a lot of acanthosis, thinning of the suprapapillary ridges. So I was thinking psoriasis.
Yep. So this is again a classic plaque of psoriasis where you get the psoriasiform bulbous sweaty ridges, the suprapapillary thinning, the constant hyperkeratosis, lots of neutrophils in the cornified layer. So that would be psoriasis. Good. Everybody good with that? Okay. Classic silver plaque of psoriasis. So in the next class, so first of all, I know the Goodman residents do, but so if you guys can tell me, does everybody have SPI 1, SPI 2, SPI test, SPI B1, and SPI B2?
We only have SPI 1 and 2.
You don't have anything else?
No.
No.
Yeah.
Oh, he didn't even send you. I told him specifically to send it to you guys. Okay, so as soon as I get out of this, I'm going to tell him. So you guys will get this. So you should have 1, 2, 3, 4, 5 study sets. Okay, SPI 1, SPI 2, SPI test, SPI B1, and SPI B2. Okay. Be prepared with that because at any time I'll just say like, let's do this particular study set revision. Okay. Next week, however, I am going to teach you guys granulomatous diseases. Okay. So I'll cover granulomatous diseases in 2 parts. So next week, I'm going to just teach you guys granulomatous diseases, not the neoplastic entities. Okay. So is there, I'll have to look, I think I'm actually, my kids have a fencing tournament next weekend. So we'll be leaving on Friday for, I don't even know where I'm going. It's somewhere in California, but I'll have to check what time my flight is. But do you think instead of 11, we can meet at 10, which would be 7 a.m. in the morning for you guys? Would that be okay?
Yeah, that's
that'd
fine.
be fine.
Sure.
Okay, but I will confirm that because I'm not exactly sure what time my flight is. So, but that's what we are going to do. As soon as I'm done with you guys, guys will be receiving those study sets. But for next week, I'm just going to be teaching you all. So that's going to be the granulomatous stuff. So you already have the inflammatory derm PowerPoint, so you can see the classification of the inflammatory granulomatous diseases in there. I'll be largely referring to that. Okay.
So quick question. So
Yes.
for us, this was very fun. It was challenging because it was like seeing it for the first time.
Yes,
and
but
like
you
trying
guys
to
did
come up with the
amazing.
path. So we should have seen them and been like reviewing them, right? Like ideally that was the
Yes.
idea.
And I'm sorry because I was under the impression that you guys had that, but sometimes even just looking at slides without knowing, but you guys did great.
I mean, it was exciting. It was very exciting.
That shows true knowledge. That is great. But you will have plenty of other study sets to get your hands dirty with. And I will intermix, we will go through all the study sets. So you'll have eventually all the answers. But, I don't want to send you guys the answers right now because then you don't struggle and then you don't think. And I want you guys to think. So, but now you will have all those 5 study sets.
Okay, perfect. And so next week is lecture on granulomas. And then the second week is which study set to review?
So let us do SPIP2, SPIB2.
SPIB2.
B2. Okay?
Okay, we will be prepared.
Good job. Have
But
a
it was
good
fun
weekend,
this way.
everybody. What
It
is
was
that?
very fun. It was very fun this way, though. We appreciate it.
I put you right on the spot.
Hmm.
That's good. I will do that occasionally. So,
Well, we need it.
Thank you.
well, thank you. Have a good
Thank you.
weekend.
Thank you. You
Yeah.
too.
Thank you.
Thank you.
Bye.